Welcome to the webinar, PrEP, Information and Q&A. Today, this session is to inform about PrEP, a tablet that can prevent HIV. PrEP is a tablet that is free on NHS and available in your sexual health clinic, and can be a game changer in ending new cases and transmissions of HIV. To talk more about PrEP, and to give more information, how to have access to it, eligibility criteria, we have Spectrum, Sexual Health Clinic in Wigan, and we'll be talking through Spectrum, Lisa Cullen and Julie Goth. Welcome. Thank you, Lisa and Julie, for being here in the webinar. After the presentation of Lisa and Julie, we'll have Faith Devengua and Joe Tanzer. They are both community engagement and development workers at PHA for Equality, and they'll talk about the difficulty of access of the most at-risk population of having access to PrEP. So I'll start asking Lisa and Julie to share the presentation.
Okay, so bear with me while I share my screen. Okay, so everybody welcome. And as we've discussed, we're just going to be discussing about PrEP today. So during this presentation, we're going to discuss what is PrEP, how it's accessed by patients, who is eligible, describe the need of PrEP for PrEP, the journey of a patient when they actually come to see us, and at the end there's a few useful websites that might be useful to you all, and a little Q&A session as well. So first one, we need to ask what it actually is PrEP. So it's actually medication to prevent the transmission of HIV. One tablet, and it contains two medications, and those are the medications. There's some side effects that some patients may have. Some may have a slight reduction of bone mineral density, rarely a rash, and there's actually a couple of ways how somebody can take this medication. So one option is that they can take it daily, and once they take a tablet every day. There is missed pill rules because everybody's human. We do forget sometimes. So if somebody does forget occasionally, it's 1 or 2 tablets occasionally in the treatment, it's usually okay. If somebody vomits, however, within an hour of taking it, they do need to replace it with a new pill because that pill will not have been absorbed into the system, so they need to replace it. So the other option is what they can do is they can do something called event-based dosing. So if that person knows that they perhaps are going to be putting themselves at risk, or they're going to be having some sex, then what they need to do, there's a rule of how they need to take it. So they take it by taking 2 tablets, 2 to 24 hours prior to sex, 1 tablet at 24 hours after the sex, and then another 48 hours after the sex. If that sex, however, is going to continue, they need to take a tablet every day until it doesn't, and then follow those rules as well. And there's just a little bit of a definition of what actually is PrEP at the top right-hand side as well. So it's pre-exposure prophylaxis, and it's a term used to describe the use of medications used to prevent the spread of disease in people who have not yet been exposed to a disease or causing agent, usually a virus. So as Elizabeth said in the introductions, this is absolutely amazing. It's a game changer. So I'll pass you over to my colleague Julie to just explain how it's actually accessed.
Can you change the screen for me, Lisa, as I need to? So currently, PrEP is free at all sexual health clinics within the UK, and it is classed as a priority within clinics. So if somebody did ring up or say they wanted to go on to PrEP, they wouldn't be turned away. Wigan and Leigh Sexual Health, this is the number, and obviously we can, for the people in our area, we can see them and put them on PrEP, but it isn't postcode bound, sexual health, so we could have somebody that would come from another area or ring our clinic to say that they now wanted to go on PrEP or to be seen, to be assessed as to whether they're eligible to do so. So just on the screen at the moment is the number for Wigan and Leigh Sexual Health. There are currently 207 patients of ours at Wigan and Leigh on PrEP, and obviously that's changing continually because we get some patients who are put onto PrEP and they may be on PrEP for a while and then they don't, but we're getting new patients coming through all the time. So these figures were from July 2022, and as I say, they're continually changing. At the moment, it's only accessed through sexual health clinics, but there are discussions going on at the minute that maybe in the future, it could be that GP surgeries are going to be able to kind of get people onto PrEP and do all the assessments and the tests that they need, which Lisa will go through shortly with you. So this is kind of watch this space. I think it would improve, obviously, the accessibility to PrEP if the GPs could get on board as well.
Thank you, Julie. So the next slide is just to explain who is actually eligible. And I will have to say, even though the first one does say your MSM group, so your men who have sex with men and your trans female, it isn't always that black and white. We do have some patients we see that may not fit the criteria, but they are actually putting themselves at risk. For example, we're in the process of trying to get some sex workers. Now they're all female that need to go on PrEP. So even though they don't fit that criteria, we've got lots of other things as well that patients, however, that will be able to have PrEP. We can prescribe it to patients aged 15 or over. And those patients need to report any condomless sex in the past 6 months and continue that they are going to continue to have some condomless sex in the next 3 to 6 months as well. They need to have had a recent HIV test, a negative test in the past 4 weeks. If they haven't, we do all the testing here. So what we do when we do, I will explain as well in another slide, we do all the full sexual health screening, which incorporates a HIV test as well. We do have point of care tests that are offered to them. If they've not had a recent HIV test, they will be given a point of care test, which is a finger prick test, and we will also test them as well. So each patient that we see through the door are completely different and may have a different route of how to get the PrEP, but at the end of the day, they will get the PrEP, and that is what is most important. So it's a funny question, isn't it? It's an obvious question why we need PrEP. We obviously need PrEP because we need to reduce HIV. We're still obviously getting people who are getting HIV, and the cost of someone's HIV care is extremely high. So to have something like PrEP is absolutely amazing. A study has been done. That's the PROW study. Very low figures, really. So 9% of MSMs who did not receive PrEP became HIV positive, but it's still, you think it's 9%, still quite high in the grand scheme of things. And obviously we can do a lot of prevention and testing, but it's not enough. We need to have been doing a little bit more. And obviously PrEP has the potential to prevent new infections. So for what's really important to our patients is what is going to happen when they actually come to the clinic, or how they actually access it as well. So once a patient is identified, and that could be that somebody For instance, Julie and I work on outreach, so we're out in the community. We might have identified a patient that way. Another way is they might just have telephoned the clinic, and depending on clinic status at that time, they perhaps can have a telephone consultation, and during that telephone consultation they will have a full medical and social history done. They will be counselled on PrEP and what that will entail for them, and to see if they're actually able to have it, and then they should attend clinic. What clinic may entail is they may attend clinic prior to actually collecting and being prescribed the PrEP, because what we need to do is we need to do the HIV and syphilis tests, we need to do gonorrhea and chlamydia, and we also need to do your UNEs, which are really important. So what the UNEs check for are sodium levels, potassium levels, magnesium, and it actually detects abnormal heart rhythms as well, and also the kidney function as well. So if there was any abnormality with those UNEs, we possibly then could refer, and they would be seen by a doctor as well. But really important that UNEs are actually done prior to them being on PrEP. Our lab that do the testing, they do a collection of courier service every day. So that is really, really good, and they get the results back really quick. So that even though they might not get the PrEP that day, they wouldn't be waiting that much longer. We usually as well give 3 months supply of medication, 3 boxes, because what we need to do is review the STI tests every 3 months. Now, what we can do in some cases, they can have a postal kit, and as long as we've got those results, we can then arrange for collection of another 3 boxes. Depending on the medication and what boxes, I know this may sound daft to you all, but depending on the boxes, sometimes we're able to post them out to somebody's house, or they may have to come and collect it, depending if we're the size of the boxes, like I've said. So sometimes we can't actually send some of them out. The UNEs are really important. I know I keep stressing that, but they only have to be done every 12 monthly, unless there's a medical need in their medical history that we have to do it a little bit more. The next slide, I will just pass over to Julie.
So on the screen in front of us, I'm not going to read them out, we'll just leave a little bit of time. So these are some PrEP experiences from people who have been in positions where they've kind of wanted PrEP or they're on PrEP. So you can have a little read through those. And they just give a little bit of background as to kind of the different types of people who may be wanting to access PrEP or are currently on it, and their experiences of it, and what a difference it might make to their life and their relationships. So I'll just leave for a couple of minutes for you to have a read through those. If you've any questions on these, obviously, or they bring up questions from reading them, we can answer them in the Q&A questions at the end. Hopefully now you've had a little bit of time to read those and take those in. So on the screen now, we've got some useful websites as well. So the top one is the PrEPster website. So if you go onto that website, they've got loads of information on there. They supply resources as well for professionals. We've actually ordered quite a few that we use in our daily work on outreach. So that's a really good website. The second one is I Want PrEP Now. So even though PrEP is currently available at sexual health clinics, you will get somebody who doesn't want to access it in that way, and they want to get it via a website, and this is where they would get it from. So there's a price for it, and if they're willing to pay it, then obviously they don't want to go through the route of sexual health clinics, they can access it on there. And before PrEP became available throughout the country at all sexual health clinics, this was kind of, unless you were on some kind of trial, this was the only route to get PrEP at the time. So that's that one. The next one is a useful website. I don't know if Lisa wants to expand on this.
Sorry everyone, yeah, it's Terence Higgins Trust, so really good website. And then the last one is your Beaver, which is all your HIV information on as well, so they're all quite good. There is a lot more information out there and websites. These are just a few that we thought would be interesting to share with you. So thank you for listening on behalf from Julie and I. So I will just end the slideshow now.
Thank you, Lisa, and thank you, Julie, for your presentation. We'll have space for questions and answers after the presentation of Faith and Joe. So now I'll ask Faith and Joe to talk a little bit the difficulties and why actually the most at-risk population are not accessing, if they are assessing or not, and who is the most at-risk population.
Great. So can you all see the presentation?
Yes.
Full screen. Great.
Yes.
Yeah. And just before we start this, I know we've got time for questions at the end, but one thing that occurred to me as Lisa and Julie were talking was this bit about daily PrEP and event-based PrEP. And it's important to stress that event-based PrEP is only for anal sex. If someone's having vaginal sex, then they need to take PrEP every day. Because we know that if you're having vaginal sex, you have to take it at least 6 out of 7 days. You have to have at least 6. And for anal sex, it's at least 4 pills a week. So the event-based dosing only works for if people are having just anal sex. Yeah, so Faith and I and Elizabeth are from BHA. This is part of the PASH partnership. It's a partnership between George House Trust, BHA for Equality and LGBT Foundation. We do a lot of work, a broad variety of outreach and interventions, and talking to people about sexual health and testing people and doing handing out condoms and things like that. But I'm going to dive straight into the reason that we're here to talk to everyone today, and that is to talk about most at-risk communities and the uptake of PrEP amongst those communities and the awareness of PrEP within those communities. So the first at-risk community that we're going to focus on is Black, Asian and minority ethnic communities. And these figures here are focusing specifically on Black African communities, because those communities in the UK are highly disproportionately affected by HIV. They make up around 2% of the population, but more than a quarter of all people living with HIV in the UK are Black Africans. So that's some really stark figures. And these figures come from the Public Health England HIV in the UK 2020 reports. You can see there as well that 1 in 6 people who are newly diagnosed with HIV are Black African. These figures don't go just for HIV. There's lots of data around high prevalence of STIs in general amongst Black ethnicities. In 2020, the average rate of STI diagnoses was around 17.4 per 1,000 for people of Black ethnicities, compared to 5.6 for other population groups. So that's nearly 3 times the amount. And despite widespread knowledge of the disproportionate effects of HIV and poor sexual health in Black communities, we still have issues of exclusion and lack of representation when it comes to research into why these groups are disproportionately affected. And for example, we're talking about PrEP here today. The biggest PrEP study that was done, and the most recent one, the PrEP Impacts trial, less than 5% of the it's actually around 24,000 participants that were in that trial. Less than 5% were Black and from non-white, British and migrant communities as well. Yeah. Yeah, I was just trying to find this figure, which I've now found. So it's 24% of participants outside of Europe. So the majority, 76%, were from people within Europe. And it's interesting to think about that in relation to what we've just learned about 1 in 6 of new diagnoses are within Black African groups. Those figures aren't being represented in the PrEP trial, in the research that we have. So the PrEP impact trial, this was the 5th big study that was done into PrEP and how it works with people. And this was a very kind of practical one. We knew by this point that it worked, and it was just about, I mean, it was already being rolled out in France and in Scotland, but the NHS, for various reasons, was dragging its feet and decided it wanted to do an impact trial instead of just having it. So they enrolled 24,255 participants. Nearly, so 96% pretty much of that was MSM, men who have sex with men, and a very small amount from Black and Asian populations, and also a very small number, 359 trans women took part in that very large scale trial as well. So trans women and Black African groups, highly at risk groups, but again, a small amount of representation in the impact trial. So there are various reasons for why that is, and we don't really have all the research that we should have into why that is. But there is, of course, a long history into why people from the Black African diaspora will be less likely to engage with sexual health services or just healthcare services in general. I've put some of the more famous instances here in the presentation. For example, there's a very well-known book called Medical Apartheid, The Dark History of Medical Experimentation on Black Americans, by Harriet Washington. That was a 2007 book that looked at this long history of how Black people living in the States were experimented on medically. And to my knowledge, that history is quite well known within those groups, and this sense of being experimented on, being treated as second-class citizens, medicine being trialed on them, but then being given to white people. For example, the example of James Marion Sims, known as the father of gynecology, did a lot of experimenting on enslaved women during the 1800s to trial new methods that he then used to go on to help save the lives of white women. So once his new techniques were learned and well practiced, he took that knowledge and used it to help white people exclusively. And then some more recent examples, The Guardian had an article with some recent data that showed that Black Britons still believed that, or still really felt that white people get better care. And of course, we saw with the COVID-19 virus that people from Black, Asian, and ethnic minority backgrounds were disproportionately affected by COVID as well. So thinking about all this in relation to PrEP, there's of course this long history about why those groups will be less likely to want to engage with sexual health services and go on to medication like PrEP, which perpetuates, of course, the higher prevalence rates within those groups. But that's not the only reason why they're at risk, but it's something that we're focusing on today. Lisa and Julie mentioned the kind of guidelines that you have when starting someone onto PrEP. And I assume that's following the Beaver guidelines, because that is also the same here, that it's MSM who report condomless anal sex in the previous 6 months and ongoing condomless sex. I'm not sure whether you ask specifically about anal sex or not, but we can see from this table that it's MSM who can be fast-tracked onto PrEP really, if they're reporting condomless anal sex, of course, because it's one of the higher risk activities. But people from other demographics are seen on a case-by-case basis, and I guess it's you know, we can see perhaps the history reflected here in this perception of who is more at risk, and that maybe feeds down into the population groups themselves. They might not perceive themselves as being at risk of HIV or not. Yeah. So Faith's going to talk a bit now about talking about this with those groups themselves and other reasons, cultural barriers, why they might be less likely to access PrEP.
Okay, hi everyone. My name is Faith Tawengwa. I'm from BHA. I'm going to talk about barriers when talking about sex in certain groups due to culture and religious backgrounds. As we all know that culture and religion has an influence on how sex is talked about, even between parents and their children. Religion can say that children need to abstain from sex until to the age when they get married. So meaning that they don't discuss with their children about sex because they don't expect them to be having sex at a young age. So they usually will talk about sex when they're about to get married, including couples. Sometimes they're not able even to discuss about sex. Usually a girl will be taught on how to please their husbands before they get married. So meaning that usually a woman will just go into marriage thinking that it's all about making the men happy. And also it has an effect on how they receive information about sex and the age as well, when they can receive the information from health workers. According to a study in 2019, young people from Asian and Black ethnic backgrounds don't discuss at all their sexual health with their parents. That's what they said, which makes it hard for other people, professionals, to even discuss about sex to those groups of people when their own parents don't talk about sex with them. So it becomes a clash of cultures, whereas especially if they're living in the Western society. And also the other difficulty that we have, some couples are not able to talk about sex openly. So that makes it difficult even when they go into the community to access our services. You find that sometimes women are a bit reserved. And then the men as well, they receive information in a way that as if they're hiding because they don't want to be seen receiving this information. So at the moment, community engagement workers are trying to sort of like bring change to this by going into the communities. Can you go on to the next slide, Joe?
Yeah. Oh, sorry. Oh no, how do I go back? Sorry, Faith, I don't know why it's doing that. There you go. Okay,
barriers to access amongst BEM communities. So due to that, the barriers include culture, language, and stigma. So those remain to be the strongest barriers. BEM people are also reluctant about treatments available like HIV, COVID, and PrEP. Like Joe said, that there's mistrust with these treatments. Sometimes they feel like, oh, why us? And they don't understand. So it's taking a lot of education in the community to let them know about how it works, about how effective it is. And sometimes language barriers, like we said, people may require translation services because it's hard for the health professionals to understand what they require. And them too, they might not understand what the professionals are saying. So that's why now community engagement workers, usually they have to be a mix of people from different cultures so that they're able to communicate with people in the community. And also the use of translators, link workers, and resources in different languages so that people can understand what exactly we're talking about when it comes to HIV, PrEP, and COVID. and also public awareness materials in different languages. Okay, thank you.
Yeah, great. Thanks, Faith. So that's a broad overview of the reasons why those groups can be less likely to know about PrEP and to be at high risk of HIV. And that's a bit of an overview of the things that we're engaged with every day as community engagement workers. I'm going to talk specifically more about trans women now in PrEP because they're also at risk of HIV and could benefit from taking PrEP. However, very similarly, there are a few UK studies in which trans women are included. And sometimes, of course, they are, and that data is there, but it hasn't been disaggregated from men who have sex with men. So these women are still being seen as gay men, essentially, and being recorded as gay men. So we don't know too much about the acceptability of PrEP amongst trans communities. Why are trans women at higher risk of HIV? That's a great question. It's a complex one. I'll briefly say here, though, they are usually quite likely to be involved in sex work due to a history of discrimination and not being able to find any other type of work, to being highly fetishized for a broad variety of reasons. They're also, therefore, exposed to sexual violence and could potentially have a diminished sense of sexual agency due to experiences of transphobia and fetishization. So engaging in risk activities like anal sex, not feeling able to negotiate condom use or to insist on condom use. There has been a study that's not based in the UK that looked at the barriers to PrEP access for trans women. And this found one being the cost. So of course it's for free in this country. However, they may not trust healthcare services, having had previous bad experiences or experiences of transphobia or being misgendered or misunderstood. So cost could be seen as a barrier if they wanted to buy it online through I Want PrEP Now or something like that, which depending on where you go is still about £19 a month, so can be relatively expensive. Concerns around side effects. Lisa and Julie mentioned risk of bone marrow density reduction, osteoporosis, particularly if people are taking PrEP every day. We do have research on the effects of that. We know that after stopping PrEP, it does return to normal, but these are concerns that people might have. Also concerns around feeling nauseous. Reluctance to visit medical professionals due to previous experiences. So like I've said, these women may have had experiences of being misgendered or not being targeted, not feeling like services are for them or that they really care about them or want to engage with them. And they want to receive PrEP from a trusted or trans-specific healthcare provider. There are also concerns about, of course, hormone interactions. Trans women that are choosing to take hormone replacement therapy might have concerns about how that's going to interact with PrEP or how the PrEP is going to interact with that, because of course that medication is really important to them. And they want to hear about other trans women, about the experiences they have with PrEP. And of course, we don't really have that. So outside of those communities, if those people are isolated and not part of a community and not in contact with other trans women who might be taking PrEP, then they're not going to know, not going to have those fears allayed by kind of in-depth discussion that could be really important for helping them access PrEP. So this study came up with some improvements, and these can be applied to the UK. And of course, these guidelines can help us think in a UK specific way about how we can encourage more trans people to come to our clinics. So review anti-discrimination policies in medical settings, and to make sure that they, explicitly protect and effectively protect trans women. and ensure that people working in those points where those trans people will be accessing PrEP, make sure that they feel confident and familiar with the issues faced by trans women and providing care for those women, ensuring that marketing and promotion of PrEP is trans inclusive, making sure that they recognize that it is for them, is something that has them in mind, that they can use to protect themselves. And of course, as we know from the work that we do in Black, Asian and minority ethnic communities, that coming up with community engagement strategies with members of the trans community would also be really effective. A big thing is disaggregating trans women from other demographics in future research. So recognizing those women with the identity that they are, and not misgendering them or recording them as something else. And expanding and developing trans-specific healthcare services. So services that really have everything that's just been said in mind. And it's vital that UK-based research into PrEP acceptability is carried out so that we can fully understand the specific barriers that they face in accessing PrEP and what can be done to remove these. Thanks.
Thank you, Joe. Thank you, Faith, for your presentation. We'll pass now for some questions and answers. I'll be asking some questions first, and I'll start actually asking for everyone wants to answer, but about actually the accessibility of PrEP. So we know that MSM, so men that have sex with men, and BAME communities, Black, Asian and other minorities, and trans as well, are disproportionately affected by HIV. We can see the PrEP, who is having access to PrEP, around 95, 99% are MSM, so men who have sex with men. How you think, or what suggestions you will have to increase the uptake of PrEP in BAME communities, Black, Asian and other minorities, and trans that are actually impacted but are not having access to PrEP? Don't know who would like to start, like to answer this question.
Yeah, I don't mind jumping in unless anyone else wants to. I mean, it's a really difficult and complicated question that has the kind of weight of history behind it, really, and it will change depending on which communities we focus on. So as we saw, if we're thinking about Black African communities, there's that whole history of being experimented on and not trusting medicine, really, and being used. I think that we need to have the key sexual health messages coming from important members of their own communities themselves. So training faith leaders to advocate for PrEP use, for example, or having community engagement workers work with kind of local community champions, so that people that are trusted, that get the same messages but in a more tailored way, so that we don't always have this kind of power play almost of the kind of white medical professional telling the other person what to do. I think that would be a really good place to start, and to prioritize them as well, because as we saw in the impact trial, you know, it's also important that MSM are prioritized, of course, and it's the uptake of PrEP within white MSM groups has been really great, and it's, you know, anecdotally I can say that a lot of people know about it and they're aware of it, or they're, you know, and they're on it as well. But we need Black Africans involved in that research as well.
Mm-hmm. Thank you, Joe. I don't know if anyone else would like to give some suggestions how other groups can have more information and can have more access to PrEP.
I think from our point of view, in outreach, it's similar to what Joe said. It's once when we are going out to groups, or it's sharing that information, sort of meeting those sort of potential people who need to be on PrEP and building those relationships up, that it isn't a horrible place to come. You're not going to be judged, and it's really good. It's really good medication. So it's yeah, it's trying to build on that, but it is difficult sometimes.
Thank you, Lisa. Faith?
Okay, from what I've noticed, let's say in the community, there's some people who can be like community champions, who sort of like speak out for people from their own countries. And because that's what I do as well when I go in the community. I usually, especially if I'm doing a group session, I usually sit next to a community champion who sort of like translates to people of their community to get the message more clear to them due to language barriers. So what I do, I'll say, okay, we're talking about this. Can you explain please more to them? And they listen to them, because those people, they understand the information, they're more educated, they understand to now explain to their people. So I think if sort of like as community engagement workers work with those people, it might help get the messages across. Because if the person that they look up to understands what we're talking about, the way they will pass on the information, they will listen to it. They've got that power to listen to the message. And I've seen it a lot every time when I'm doing my group sessions. It works very well, because those people, they are very clever. They understand information. They understand what we have, our resources. So they're very useful, those kind of people. And I think we should work with them in the community. For example, yesterday I was working with another man who was like that. It was really useful to me. And the other time I was doing a group session with women, and I have another woman who does that for me. They really listen to them, and they are very powerful. So I think if we work with those people, they will be so helpful in passing information.
Okay. So sorry for butting in again. I think as well, what Faith has just said about the language barrier is we need some resources, posters, simple information that is in different languages regarding PrEP, really just to entice them in as well. So it's breaking down those communication barriers as well.
Joe?
Yeah, I just wanted to say one last thing as well. And I'm sure sexual health clinics might not have capacity to do this, but I'm thinking for people that don't like visiting clinics, because it is just to start on PrEP, you know, you need your HIV test and your blood's taken and things like that. If there was a way for community nurses to be able to do that in community settings, to kind of do that initial consultation within a community session and be able to help hand out the PrEP in that session and in that setting as well, that could be really helpful for accessing people that otherwise aren't going to make that trip to the clinic.
Yeah, we've done some consultations and some testings within community. The only problem we've got is the UNEs. So the UNEs have to be spun on a machine in our lab, and then actually then the courier picks them up. So we've potentially we can do it, but we have to get them spun as soon as possible. So it is an option. We've done it before where we've done absolutely everything, but then we've actually tried and persuade them into coming to clinic. But it's just this 2 hour problem with the UNEs, the practical thing. The other thing about going out doing testing and prescribing is not an issue. It's the UNEs. And I mean, the good thing is usually they only have to be done every 12 monthly, so it might be just trying to persuade them to come in once. But I'm aware some people haven't got the money to get here. There's lots of other barriers for them. So as I've said, if we can get the UNEs spun on that machine within 2 hours and sent, it is a big possibility indeed.
Thank you all for brilliant ideas, some great recommendations actually, how we can speak more with the BAME communities and other communities that are not having access to PrEP. I think we have here some recommendations that we need to take it from here, like this PrEP in the community, have the champions, how to reduce the language barrier. So all useful, very useful and great ideas to improve uptake of PrEP amongst BAME communities and trans. Another questions I would like to do, because probably everyone wants to know and they are thinking about it. So we are talking about a pill, a magic, almost like a magic tablet that prevents HIV. So how actually PrEP prevents HIV, how it works, how the tablet works. The question is for everyone that would like to answer.
Again, happy to jump in there, and it's obviously very complicated and refers to the life cycle of HIV itself and how that works once it gets into the body and starts to replicate using the white blood cells, the CD4 cells. So PrEP has been developed from medication that already exists and is already taken by millions of people across the globe. It's developed from HIV medication itself. And the way that medication works is that it essentially interrupts the HIV life cycle. So as it kind of colonizes the CD4 cell and turns that into a factory for making more HIV within the body, it intervenes with that process at multiple different stages. And that's why sometimes it's referred to as a cocktail drug. When people take HIV medication, they're taking a mixture of different drugs, and it's because that life cycle is being intervened at multiple different stages. And in the history of HIV medication, that's when it really started to work. It was around 1996, when people trialed 3 different drugs, trying to intervene at 3 different stages instead of just at 1 stage or at 2 stages, because we found that if we found a drug that just did one thing, it would work for a bit, but then the HIV would find a way to get through. So the different drugs that people take in that cocktail are split into different groups, mainly 5 different groups. And I won't go into too much detail now. There are some really good videos about this on YouTube. If you just Google like HIV life cycle and HIV medication. But as Lisa mentioned earlier, PrEP is made up of 2 drugs, tenofovir and emtricitabine. And these 2 drugs are known as nucleoside or nucleotide reverse transcriptase inhibitors. So they're 2 drugs that once you take them, they kind of hang around in your body, in your blood cells, and they stop the HIV from replicating, in that instead of kind of fusing with different parts of the blood cell, they will kind of fuse with that medication that's there instead, which is kind of a red herring and kind of stops it from being able to kind of replicate itself. And you can see that in the name. It's so nucleoside reverse transcriptase inhibitors. It stops that process, which if I had a diagram, I could explain in more detail. But essentially, it's medication, 2 types of medication that is already used in HIV medication, and it's enough to stop HIV from taking hold in the body. But if you've already seroconverted and you're known as HIV positive, as you're living with HIV already, then PrEP isn't enough to suppress the viral load. It's just enough medication to stop it from taking hold in the first place. And that is, of course, why we always do a HIV test when starting someone on PrEP, or that's why sexual health clinics do that. Because if you're living with HIV, you need to be taking HIV, a fuller regimen of medication.
Thank you, Joe. Don't know if anyone else would like to add. No?
No, that was perfect.
Thank you then, Joe, for your perfect answer about how PrEP works. I just want now to say thank you for everyone that is here in the panel, and to let also know that this PrEP webinar is inside of PrEP Awareness Week that is happening during this week. We're having like amazing campaign through social media to create awareness and information about this fantastic tablet that prevent HIV, and with other tools like condom use, U equals U, we can actually prevent HIV, and you can end new transmissions and end HIV by 2030. This webinar will be available across our social media and our YouTube, BHA YouTube page. Thank you again, Lisa and Julie from Spectrum, and thank you also Faith and Joe from DHA for Equality. I'm Elizabeth, by the way, from DHA as well. See you then, bye.
Thank you,
Thank you.
bye.
Bye.